our fabulous logo. Thank you, Dr. Santosh, Professor Santosh, or whoever worked with you for it. Our sponsors for today's event, MSN Laboratories. We will have a brief presentation from them at the end. And a quick note on our program for today. So visually you can see here we have an inaugural message from Professor Minerva Thame, or message from Deputy Dean Annette Crawford Sykes, Dr. Annette Crawford Sykes, as well as a message from our head of school, Dr. Theon Jones, before we get to our featured presentation today from Ms. Tiffany Brown, moderated by Dr. Rachel Ann Barras. So let's get started. First of all, Professor Thame, please, you can come to the stage. A round of applause, please.
Thank you very much, Chair. Inaugural indeed. Head of School, Dr. Jones, Professor Santosh, our colleagues, our students. The lecture hall looks so nice, you know. Face to face is what I believe in, right? So I really just enjoy seeing you here this afternoon. It really gives me great pleasure to bring and to have the opportunity to bring greetings at this inaugural case presentation forum. This is really an excellent initiative that has been put on by Head of School and by Professor Santosh, as we seek to develop our students not only in dentistry, but in public speaking and in sharing the work that they're doing to help them get ready for their publication, and it's all part of your development. We have encouraged that our students should do research. They should be well-rounded, because you all are going to become your own consultants in time to come. And research is actually a vehicle that we use to gain new knowledge and to guide our practice. Evidence-based medicine is what should allow us to decide how we do things and why we do things. And our practice should be steeped in the foundation and rooted in hard evidence. It is for this reason that an event like this is so important, because the students are now given the opportunity. Because when you're doing a case presentation, I'm sure you've had to go to read the literature, to pull your things together based on the work that you're going to present to us on. So this is all good practice. The introduction of these case presentations will enhance the students' development, and it will take them through different processes as they prepare this. As we engage in this type of activity, it is important that we recognize the importance of not only the presentation, but as I said, in the preparation, as you'll have to interpret the studies that you'll have to read, because I'm sure you just didn't get up and just do this case presentation. There's a lot of work that must have gone on behind the scenes. And it's important for our students to be able to dissect information that they read and to look and see in the literature what is valid and what is not valid as you prepare. Our students must have the ability, as I said, to decipher the studies that are, to see those that are properly conducted from those that are not. And the Case Presentation Forum has created this sort of forum for you to do this, to share your work with us, and to disseminate. So to Head of School and Prof. Santosh and your team, thank you very much for this initiative, and I look forward to us having many more of these. Thank you very much.
Thank you so much, Professor. All right, next we'll go to our message from Deputy Dean, Dr. Annette Crawford Sykes.
Hi. Good afternoon. I have to say that it is, before I start, it's a real pleasure to see Dr. Peart because I knew him as a student, and it's really, really nice to see him as a professional. Very nice indeed. Head of School, Dr. Theon Jones, Professor Santosh, Dr. Peart, the chair, students, all. I'm really quite happy to be here and quite delighted to have been invited to speak. It is always a joy to experience the growth of students, starting off as impressionable novices and ending as young medical stroke dental professionals. I use medical in the general sense, ready to take on the care of their patients. Part of that growth is seeing them begin to understand the importance of peer review of their practice and their own contribution to the field of practice. Part of being a university, do well.
Thank you so much, Doc. All right, thank you so much, Dr. Crawford Sachs. Next we have Dr. Jones, head of the School of Dentistry. Round of applause. I had to do it.
Yeah, thank you, Dr. Chair, Dr. Kenneth Feart, Dean, Professor Thame, Deputy Dean, Dr. Crawford Sachs, Professor Santosh, MSN, my respect, sir, and students, persons online, a pleasant good afternoon. I stand here as a very honored head of school to see one of Professor Santosh's other dreams come true. This has been a while in the making, and we are of the view that it will lead to many more such presentations. I also want to thank the sponsors at this point for coming on board, because without them, none of this afternoon would be possible. The plan is to have one presentation each quarter. So we look forward to the class of 2024 to provide the next 3 for the year, and then to 2025, on and on and on. We really want to say to our speaker this afternoon, Miss Brown, soon to be Dr. Brown, you know, we are here to support you this afternoon, as you can see by the turnout. Wish you all the best in the presentation. And lastly but not least, I know I saw Dr. Barras, who is our moderator, here. Thank you all for coming. So, hand it back over to the chair. Looking forward to this afternoon's presentation.
Thank you, sir. All right, time for our featured presentation. The star of the show, Miss Brown. We're looking forward to it. I had an opportunity to get a glimpse of it, and I know that the crowd will really enjoy it, and we'll learn a lot. So, our final year student, Miss Tiffany Brown, please.
Good afternoon, everyone. Dean, Deputy Dean, Professor Santosh, the head of school, Dr. Jones. And good afternoon to all of the students here. Thank you so much for coming out. And before I begin, I just want to give a special thank you to the sponsors, MSN Laboratories. I really appreciate it. And I thank you for sponsoring this segment of Dentistry Talks. So today we're going to be talking about the effective management of a symptomatic tooth in an Afro-Caribbean teenage patient, and it is using a preservative approach. So before I begin, I just want to introduce myself. My name is Tiffany Brown. I am a final year student. Some of you may know me from the clinical floor. So I hope you enjoy the presentation. So before we begin, I just want to give you guys a rundown on what we're going to be doing today. So the learning objectives is basically just what you expect to learn today. Then we're going to jump into a little pre-quiz. Don't get scared, it's nothing hard. And then we're going to jump into a little discussion. We're going to talk about some cases that I have done at the clinic, as well as recap what we have learned today. So to begin, the learning outcomes which we hope to achieve by the end of the presentation is I hope you guys will be enlightened about reversible versus irreversible pulpitis, as well as direct versus indirect pulp capping. Also, I want to enlighten you guys a little bit about the different materials that can be used, as well as the treatment strategies and some follow-up strategies. Okay, so everybody seem kind of dead. So before we begin, I want to just do a quick little icebreaker. I want 2 volunteers. I don't want to have to choose anyone. I'm feeling choosy this afternoon. No volunteers? I see a hand. No, you could come. Come. Come down. I need one other person. I see Alyssa Frey, yes. Another 5th year student, great. All right, so the instructions of the icebreaker. So we have our 2 players. The instructions are pretty simple. First, I'm going to show you guys a screen full of images, and your goal is to remember as many images and details as possible. Because as you know, as good clinicians, we have to have good memory, and we have to pick up on details, right? So the key here is that once an image is said, it cannot be said again. You'll be disqualified, and you will lose, okay? So you can have 30 seconds to look at the screen. Ready? $30 seconds starting now. Remember the details as well, guys. It's just not about the photos, okay? Ten more seconds. Okay, so face the crowd. And now I want Miss Alyssa Frey to tell me one image. Oh, you want to go first? What's your name, sir?
Prince Nigel Brand.
Oh, Prince Nigel, okay. Okay, so usually it's ladies first, but I guess Prince Nigel has to go first. So Prince Nigel, can you name one image that you saw on the screen?
I remember seeing some teeth with decay.
How many teeth?
3 teeth.
Okay. I know Miss Alyssa Frey, can you name an image that you saw on the screen? What was the breed? Okay, I'm gonna make it easier. What was the color of the puppy? What was the color of the puppy? And? Okay. Prince Nigel, your turn.
I remember seeing a laptop. I have no idea what brand it is.
Okay. Back to Alyssa Frey. Can you tell me another image that you saw on the screen? Okay. Was it caramel popcorn? Okay, it was regular popcorn. All right, back to Prince Nigel. Tell me something else you saw on the screen.
The MSN and their logo.
Okay, can you recall the colors that were in the logo?
I'm colorblind, I think.
Close enough. Good try. All right, back to Alyssa Frey. Okay, nice. In time for Valentine's Day. Back to Prince Nigel. Can you call something that you remember seeing?
A toothbrush.
A toothbrush?
They're like images of toothbrushes, but
Uh-huh.
they're on different planes.
Okay, but how many toothbrushes were there?
4 or 2.
Okay. And back to Alyssa.
There's a lady
Mm-hmm.
here.
Mm-hmm.
She's in pain. She's holding her left mandible.
Okay. That was good. Back to you, Prince Nigel.
Okay. On the scientific part of it,
Mm-hmm.
panoramic X-ray.
Okay. No, can you name one dental appliance that was in the X-ray?
I remember seeing, I'm pretty sure, it's not an appliance though.
Mm-hmm.
I'm pretty sure I remember seeing some fillings, and I think I'm wrong.
Okay, I will accept that answer. All right, back to Alyssa Frey. Okay, what were the colors of the candy? Name 3 colors. Okay. Mm-hmm. Okay, you got to pass. Y'all doing good so far and probably made this too easy. Back to Prince Nigel. Tell me something you remember seeing.
There's a basket there.
Okay, what is in the basket?
There's some fruits in there. I'm a countryman, and I still don't know exactly. What fruits those are. But I think there's the American pear. That's a fruit.
Mm-hmm.
Yeah, that's it.
You can name one other fruit. All right, back to Miss Frey. Name something that you saw on the screen.
So there was a clinician
Mm-hmm.
gloves,
Mm-hmm.
a basic setup.
Okay. Okay. You got a clap for that one. And back to Prince Nigel. Wait, you getting help from the crowd? That is not allowed.
I don't remember.
So you tapping out? Okay. All right, so everybody give Miss Frey a clap. Thank you for volunteering. And thank you for being such a good volunteer. You get a thanks, Prince Nigel. All right, so now we can jump into the meat of the matter. So this is just a small pre-quiz just so I could gauge the knowledge basis of everybody. It's nothing hard. As you can see the questions. So if anybody just want to volunteer themselves to answer, just so I could get an idea of where everybody is at. Anybody want to volunteer for question number 1? All right, I'm going to choose Brittany Gordon from 2024. What is pulpitis, Brittany? No, it's fine. You can speak. Okay, that's a good answer. I agree. And for question number 2. Oh, can you repeat the answer? Oh, me? Oh, sorry, my apologies. So she said that pulpitis is inflammation of the pulp. We all agree on that? Yes? Okay, good. So for question number 2 is what is pulp capping? Anybody has an idea of what pulp capping is? You can shout out the answer. There are no wrong answers today. Today only. You could take the chance. So nobody knows what pulp capping is? Okay, so for question number 3, this one is a multiple choice. Everybody got a multiple choice, right? We in dentistry, come on, we gotta be good at multiple choice. So when a pulp cap patient is identified, your treatment should be immediately, within 6 months, after 6 months, or within a year. Anybody got an idea of what the answer could be? A? Miss Crawford said A, that's correct. All righty. Yeah, give a clap. All right, so today's topic, as you can see from the pre-quiz, is going to be pulpitis, and we're going to go into reversible and irreversible, and then we're going to jump into pulp capping, direct and indirect. So before we get into the cases, I just want to give a little rundown of what pulpitis is so we know exactly what we're talking about, right? So whenever I am faced with a challenging topic, I like to break it down into small parts because it's easier to manage, right? So pulpitis is basically the combination of 2 words. It is pulp and itis. Pulp meaning, as Brittany said, the nerves and the blood vessels that are found in the tooth. And itis means inflammation. So when these 2 are combined, what you get? And which is? Exactly. So pulpitis can have 2 outcomes. It could either be reversible or it could be irreversible. And if you think that reversible is too much of a big word, we could change out that word for changeable. So reversible pulpitis just means changeable inflammation of the pulp, right? Everybody understand? And then for irreversible, we could change out irreversible for unchangeable. So that would just become unchangeable inflammation of the pulp. So you see how I could break things down? So now, whenever we are faced with a case, especially at clinic, or it could be just some random person coming up to you saying, my tooth hurts me, you could look in my mouth. Like, it happens to me so much time over Christmas. Like, my family would just come up to me and be like, I having a pain. And they would be like over the dinner table with like phone camera, like trying to figure out what's wrong with the mouth. I'm sure we've all been there. But the case summary says a 16-year-old male of Afro-Caribbean descent presented to the UMDP for the examination of a symptomatic tooth. Now, while I'm reading this case summary, I want you guys to pay attention to the details like we did before. So, his vitals were within normal limits. The medical, social, and dental history were all non-contributory. However, there was a large cavity seen in tooth number 14. This tooth tested positive to cold testing, and the patient was managed with symptomatic treatment following investigation. So, as good clinicians, we are all, we all looking for a diagnosis, right? whenever we presented with a case, the end goal should always be to get a diagnosis for the patient so that we can properly do treatment planning. So for this case, when I read the summary, what jumped out to me was the large cavity that was seen on tooth number 14. That wouldn't jump out to y'all as well? Like if somebody come to you with pain and you're doing an examination and the tooth has a big hole in it, the first thing that will come to mind is this tooth is probably the cause of the issue, correct? So that's how we're gonna use our diagnostic skills, so you're gonna pay attention to the details. So, we just found out that this tooth has a big hole and the patient having pain. So now we can get into the causes of pulpitis, right? Because we already went through what pulpitis is, so we kind of closer to a little diagnosis, right? But now we could get into the causes of pulpitis. So it could be a fracture of a crown, it could be thermal changes, it could be chemical irritation, it could be traumatic exposure. But the biggest one here, I got hit the biggest on the screen for a reason, is dental caries. We could all agree? Like the main reason for pulpitis is dental caries. And that tooth number 14, if we can remember, it had a big cavity. So we're getting closer to a diagnosis. So, what if this same patient came to you and the patient had a chief complaint, right? So we're going through this case, we're trying to get this diagnosis. So what if the patient was to say to you,
"Hi doc, I'm here because I'm feeling a lot of pain."
so you're feeling pain. So we're trying to get a diagnosis, right? But where are you feeling the pain?
Doc, I'm feeling the pain on the left part of my upper jaw from last year.
Okay, from last year. So we're getting a bit closer now to the diagnosis, right? So can you describe this pain to me?
It's like something is burning me. Yes.
Okay. And on a scale of 1 to 10, how bad you would say the pain is?
Like a 5, doc.
So I see all these details we can use to get to a diagnosis, right? Does anything trigger the pain?
Every time I eat, doc, the pain gets worse.
So you see, by asking these questions, we get in some more details of the case, which would then help us to get a diagnosis, right? So one last question I have for my patient. How long does the pain last?
The pain lasts for around 5 seconds, doc.
Okay. So as I said before, thank you, Garrison. So as I said before, good clinicians are people who listen to details, right? People who listen to their patients, people who could put themselves in a patient's shoes in order to get a diagnosis so we could get a treatment plan, correct? So who in here was listening just now to what the patient was saying? Oh, I see a hand at the back. I see a hand. Who's this person? Oh, can you come down to the stage? No. Okay, so Ms. Peters isn't coming. Anybody else was listening really well just now when the patient was saying their details? I seen somebody looking at me. No, it's you. You could come down. Yes.
There you go.
All right, so it's going to be something very easy. So, you see, since you can't hear her.
No, you go. You go right ahead.
Based on the patient diagnostic, and she said that it was 5, I would say it's reversible.
But you look at the other side, you look at irreversible. Anything from irreversible much?
Pain, dull, continuous pain. No, because it wasn't severe. I would not, because it wasn't severe, because it was say off. Let's say off and off. I said no. I think it's reversible.
But what about point number 5? Irreversible. Would it not match?
Duration of pain persists on removal of. That's true.
So would it not match?
Yes, that's true. Yes.
Thank you.
So now we can reveal these answers. So the patient said that the pain was a burning sensation. It lasted 5 seconds. So that's kind of short, right? So it matches up with the reversible pulpitis symptoms. However, we see kind of an overlapping when it comes to the irreversible, where she said that food packed in the tooth causes pain. So sometimes, even though it may lean to one side, you can still have overlapping symptoms. But you are right. I agree with the reversible pulpitis because it's leaning more to one side. We could agree. We got more green on the left than on the right, correct? Right. So one important thing to note when it comes to reversible pulpitis is treatment as soon as possible is best because we don't want it to lead to irreversible pulpitis, right? So remember I was asking before when you should treat it. The answer was immediately, so Ms. Crawford was correct. So if the infection extends periapical for the irreversible, then that is basically periodontitis. So again, if it's irreversible, the goal is still to treat it as soon as possible because diseases can progress. So we went through the chief complaint. We went through the history of chief complaint. So we were getting some case details, something to bring us closer to a diagnosis. But other diagnostic aids that we use, especially at clinic, the main one being radiographs. Radiographs are really important when it comes to diagnosing because it allows you to see what you can't see with your naked eye. So this is the radiograph taken on this patient. It was a radiograph of tooth number 14, a PA. And as you can see, there's a large radiolucency into the dentin, not into the pulp though. And also it has the characteristic inverted V shape, that occlusal caries have, because the caries usually spreads along the DEJ before it deepens into the tooth, right? All right, so another diagnostic aid that we use is pulp testing. And pulp testing is important because number one, it allows you to test the vitality of the tooth. And then number two, it allows you to recreate the symptoms that the patient is feeling, right? And it allows you to get like a first-hand experience at what the patient was trying to describe to you before. That's correct. So controls are used to get a baseline reaction of what you would consider a healthy tooth. So you can then compare it to the reaction you got from the suspected faulty tooth. Understand? Right, so you dry the tooth, you spray the endo ice onto the cotton pellets and you apply it to the tooth and then you gauge the reaction. So a patient might say to you, one would say, the pain lasts, it comes quickly, it goes quickly. And yes, that is helpful, but with pulp testing, you get like a actual idea of how long it lasts because you could time the reaction that you got from the patient. So instead of just saying, oh, it goes quickly and it comes quickly, the pain actually lasts for 5 seconds, right? And that's really helpful when diagnosing teeth. So the diagnosis that we got correctly stated was reversible pulpitis, and then somebody probably wondering where the acute come from, right? Well, acute simply means that it wasn't happening for long. So this was the first time this patient presented with problems with this tooth, and based on that, we would consider it or classify it as acute reversible pulpitis. So the treatment plan was drafted up once the diagnosis was achieved, and for this patient, we administered amoxicillin 500 milligrams at the initial visit, and then we went in with an indirect pulp cap using IRM, and then a definitive composite restoration was placed. So, some people might be asking, but why antibiotics, right? Because there was no infection with the tooth. We never saw any radiolucencies at the periapical portion of the tooth. However, even though antibiotics may not be a treatment for pulpitis, this case was an emergency case. So, usually on the clinical floor, there's one person on emergency, and there may be 5 emergency patients. So time management is really, really important when dealing with emergency cases. And as we saw from before, the cavity was so big and it clearly would have taken a lot of time to excavate these caries and place a restoration. So the treatment that day was just a prescription so as to not allow the reversible pulpitis to progress to irreversible pulpitis, right? Because we know that antibiotics have anti-inflammatory properties. So hopefully that would have caused the tooth to become asymptomatic by the next visit, correct? So this is what a prescription may look like that we write at clinic. So you have the patient's name, the address, you will have the age, the gender of the patient, and the most important part is the drugs that you see here in the body of this prescription. So The amoxicillin was given 500 milligrams. You're gonna have your dispense, which is how much you will be, well, the pharmacist will be giving to the patient. And then you also have the last line, which is instructions to the patient on how to take this medication. Other prescriptions usually also have the amount of refills if that's applicable, and if generic form is allowed. And the generic form is just basically like the non-name brand, right? And you will have the clinician's signature, the dates, as well as the registration number of the clinician. So these are a list of other medications that could have been prescribed or that we use often at the clinic. The first column is just analgesics, which are painkillers. And we have ibuprofen, cataflam, naproxen. Like all of these are stuff that we use regularly at clinic, and the dispense is listed next to it, as well as the instructions to the patient. The same thing for the antibiotics. So this is just a list of some common antibiotics that we use at the clinic, along with their dispensation and the instructions to the patient. You will also see some keynotes to the right of the screen. For example, metronidazole, you can't give it with alcohol. So if you prescribe this to a patient, you have to remember to tell them no drinking. And at the bottom, we have Young's rule, which may be familiar to some people. And it's basically just calculating the child dose of these medications. So these are the clinical images of the tooth that was presented from before, number 14. So at the initial visit, as we said, the prescription was given. But then at the second visit, the tooth was excavated. We placed a temporary restoration as the pulp cap, and this was basically just to help the tooth heal itself, right? And we're going to get into that a bit more at the end. So this is an image of the IRM that was placed. Any first year students here? Yes? I can see a hand of a first year student. Wait, right here is so how many saying the hands? Okay, you could come to the front. Or you don't have to come. Just tell me what tooth is this in the image. Simple question. Okay, is it an upper or lower? Lower, try again. Okay, so she could get a praise. Thank you for volunteering. So in the second image, we also have the tooth once it was excavated. And as you can see, this cavity was big and it was really deep. So the little white thing that you see like in the middle of the prep is actually a liner that was placed to keep the pulp asymptomatic. Understand? So I have a question for who doing dental anatomy? Which year group? First years? Second? I can't remember, it was so long ago. Who doing dental anatomy? 2020 who? Just throw the question. Okay, so whoever wants to answer. So what dental anatomy was lost and regained due to the cavity? Anybody could identify some dental anatomy that we regained with the restoration? Oh, Dr. Jones said a bleak ridge, but he kind of cheating because he know everything. Anybody else could tell me some stuff that was lost and regained? What about the cusps? Okay, there you go. Yes, and we can see that we regained the cusps on the final restoration, right? So, as I said, the liner was placed and the final restoration was used with composite, and this is the polished and finished restoration. So let us get into a bit about the pulp capping that was done. So the first case was an example of an indirect pulp cap. And we understand that it's indirect because the medicament was not placed directly onto the pulp, right? We understand that concept. And the main goal when it comes to pulp capping is the formation of the dentin barrier. So that's why I placed the temporary first, and then I placed the final restoration afterwards. So I was trying to allow the body to heal the tooth, become asymptomatic before I place the definitive restoration, right? So if you can see on the diagram, this is just how the tooth would look if it was sectioned in half. And you can see the nerve tissue. You could also see the discolored dentin. That would be like the last layer that was left just so that we didn't get a pulp exposure. And then on top of that, you will have the pulp cap, and then you will have your either the temporary or your definitive restoration. So this was a case of indirect pulp capping, but of course we could do direct pulp capping, right? And the end goal of both is the same, to have that reparative or secondary dentin bridge formed. So I can just show y'all a case that I did. So this case reads, an 86-year-old patient presented to the clinic with a chief complaint of tooth sensitivity, described as a nagging sensitivity in the back of the tooth. And who answered the question about the symptoms? You remember which side you remember which side nagging fell under? Was it reversible or irreversible? Yes, irreversible. So y'all listening, that's so good. So the health history of this patient revealed Parkinson's disease, and upon investigation, tooth number 2 had a curiously related tooth fracture, and this tooth fracture resulted in a pinpoint exposure of the pulp. So since the pulp was exposed, this patient required a direct pulp cap. So that's what we did. So the treatment was you clean up the area, you identify the source of the bleeding, and you stop the bleeding with, you could use we used hemostatic agent as well as a cotton pellet under pressure to just control the bleeding before the restoration was placed. Because it's really important to note, I have it in red, you cannot place the restoration unless the bleeding is controlled, right? So we cleaned up the area, we placed the pulp cap, and then we placed a temporary restoration. And once again, this temporary restoration was placed just so that the tooth would potentially become asymptomatic. So that was the image of the tooth. So even though we did an indirect pulp cap on the first case and a direct pulp cap on the second case, the treatments were kind of the same. However, the outcomes were extremely different. So for the first case, the tooth became asymptomatic. I placed the definitive restoration, and the tooth was fine. The patient hasn't complained of any symptoms since. So I would say that that case was successful. However, for the second case, the patient came back with a symptomatic tooth. So that brings me into dealing with changing treatment plans, right? Because sometimes things don't go as we plan. So initially we placed a pulp cap, but that didn't work. So as you can see here, there was no reparative dentin seen in this radiograph, and this was at the 6-week recall visit. The tooth was symptomatic to the point where the symptoms that we got before, even though they were kind of leaning more towards irreversible pulpitis, when she came back, it was definitely signs of irreversible pulpitis. So this patient was suggested to either do a root canal or extraction. And of course, we were doing conservative dentistry, so we tried to do the root canal at first, right? But unfortunately, that didn't work. So when I went home, I was wondering, like, what could I have done to make this treatment a success? And I decided to research some different materials. So remember, we used the calcium hydroxide in the second case with the direct pulp cap, and we used the IRM in the first case with the indirect pulp cap, right? So I wanted to research like which one would have been better to use. And according to the research, the dical, which is the calcium hydroxide, it should have worked better technically than the IRM. However, at the end of the research, they said that the results were the same, so I didn't really get any help from that. In the second research that I was doing, I wanted to compare the dical that I use for the direct pulp cap with something much better, which they call biodentin. Now, biodentin is this amazing material. It has 100% success rate according to the comparative studies done, whereas dical, which I used, only had 92.6% success rate. So I was here thinking, I wonder if I'd used the biodentin if the tooth would have become asymptomatic. So lastly, I compared MTA with the biodentin because I remember in Clin Prep, like when we were talking about pulp capping or any vital pulp therapy, the first thing here is MTA. I write 2024, right? MTA for everything, right? So when I did the research, according to the research, the biodentin actually had better results than MTA, and it showed that the clinical and radiographic success rates were much higher than the MTA. So, talking back to treatment strategies now, when a patient, the treatment plan doesn't go as you wanted it to. So the first thing and the most important thing is patient management. So patient management can be broken down into behavior management, and it can also be broken down into dental management. And we kind of covered dental management already, which is like the procedures and the medications that we use. So we could go into the behavior management. Behavior management is probably my favorite part of dentistry, because it's the part where you get to not only cater to the teeth, but cater to your patient, right? So the first part of behavior management is pain management. And I know everybody says when they come into the office, I hate dentists, right? Everybody could agree with me. That's the first thing they say. I hate dentists. What is a torture chamber? Actually, the patient in the case number 2, she calls my cubicle a torture chamber. So that just gives you an idea of the reactions people have towards dentists. So for pain management, trust is key. So usually I remember Dr. Jones had said that when a patient raises their hand, because as we know, when we give in LA and we're doing a procedure, we usually tell the patient, if you're feeling any pain, you raise the left hand, and then we're going to stop and we'll give more medication if necessary. But one big takeaway from pain management is that we need to respect this left hand. When a patient is in pain, you need to reel and come again, either give more medication, because at the end of the day, if the patient is not in pain, if the patient is in pain, they won't trust you, and it will be less likely to accept the treatment plan, right? So effective pain management takes away the fear. The second part is patient management. And anybody got an idea what this is without reading the screen? No? Okay, so patient management is basically just rapport building, right? So you could think of the first pain management section as dealing with the physical, and I want you to think of patient management as dealing with the emotions of the patient, putting yourself in the patient's shoes, trying to understand what the patient is going through, trying to build a good connection with the patient, you understand? So rapport is essential, and building good rapport will make follow-up much easier because the patient gonna want to come back. So the last part of behavior management is patient education, and this was a big role when it came to the unsuccessful pulp cap that we did, because before the pulp cap was done, the patient would have been made aware that it could have been unsuccessful. So the goal when it comes to patient management should always be to educate and empower the patient, and that's the only way you could get true informed consent. It's really easy to get consent, right? Because if somebody don't know, they can just go with it. But informed consent is the one that is hard to get, because you have to take the time out to explain and allow the patient to feel like they're a team, part of the dental team, part of their patient, part of their treatment plan. So I remember this part, what made me even choose the case was this section of the PowerPoint, patient education. I remember when I ended up extracting the patient's tooth for the failed pulp cap, I put in the gauze, the patient was advised to bite down, and then she said she had a speech to make. So I start freaking out now, right? Because I just say, she can say she never wanted to take out the tooth, I said I was gonna save the tooth, so what's gonna get her nervous. But she actually said to me that this was the first time she went to a office and felt like she was a part of the dental team. And that really made me feel really good, because even though at the end the treatment was not what she wanted, she said that it allowed her to accept the extraction much easier. So patient education is really important, guys. So following up on the behavior management, I just have listed some little things I do at the clinic that I have started doing just to try to build some connections with my patients. So number one is keeping the line of communication open at all times. It might be hard, like when you go on vacation and a patient calling your phone saying, I want an appointment. As soon as you come back, I want an appointment. Still keep the line of communication open, because at the end of the day, you need your patients as much as they need you, right? So the second one is tailoring the clinical experience to each patient. I remember I had a patient who was diagnosed with arthritis of the neck, and every time she was scheduled to come and see me at the clinic, I would bring a little neck pillow for her. And no matter how good the restoration looked, she ain't gonna remember the restoration, but what she remembered was that little neck pillow that I brought for her. And also incentives. I love incentives, like, as you can see, I bring like a bag of gifts. And I always implement this when it comes to my pediatric patients, because even though they may just be coming for the toys, at least they're coming. And they're, getting excited about dentistry. So incentives really work. All right, so now we can look at some follow-up strategies. So the first thing is the 6-week visit. This is a really important visit. You go through the chief complaints again. You will find out if the tooth has become asymptomatic now, or if the tooth has remained symptomatic. And it's really important to just gauge how the patient feeling and doing with the treatment. So the next part is clinical evaluation. Anybody knows what that is? No? McCary? Pardon? I asked if you know what clinical evaluation is or what it could be. Mm-hmm. Okay, I guess. So clinical evaluation is really important when it comes to follow-up, because it allows you to, you're going to be checking the integrity of the restorations that you have placed. You're going to be checking like the, check to see if it's there, because most of the time when you place a temporary restoration, they're so prone to coming loose or falling out. So it's really important that you check that it's still there, check the margins, make sure there's no leakage. And also you're going to be checking for signs of like swellings, any sign of strap formation, any abscess formation, because that then leads to a diagnosis of pulpal necrosis. So then you're going to redo your whole treatment plan again, right? So the other part is doing further investigations, like radiographic investigations. So like I said, the dentin bridge can be seen on a radiograph. So it's best to be sure than unsure. So if you're not sure if it's formed, just take a radiograph to see, right? As opposed to you going into the tooth, causing problems again and making the tooth symptomatic again, right? And then lastly, while treating the tooth, before you place the permanent restoration, always check for bleeding, because what I said before, exactly, you cannot pulp cap until the bleeding stops. And you can't do a definitive restoration until the bleeding stops either. So this was my case that I presented initially with the indirect pulp cap, comparing it to another case that I was researching. This case was successful though, so I wasn't really too, worried about the outcome for this case. And this was of the 16-year-old patient that had the big cavity in tooth number 14. So as we know, we did the prescriptions first, then we did the temporary restoration, then we did the definitive restoration, right? So I researched the case. It was really similar. It was a fit 24-year-old male patient presented for a routine dental checkup. However, he had no symptoms. So that's one difference than my case, right? Because my patient came in symptomatic. However, this patient, he had no symptoms. Clinical examination, however, revealed a cavitated carious lesion on the lower left number 8. So a periapical radiograph revealed a diagnosis of gross caries for the lower left number 8. After discussing the various treatment options, the patient agreed to indirect pulp capping, and a 3mm layer of biodentin was applied over the affected layer of dentin. Remember we spoke about the biodentin before and how good it was? So this case actually used the biodentin. And as we can see, a year later, the patient was reviewed, and the patient reported that the tooth remained asymptomatic, and clinically and radiographically, there were no signs of endodontic disease, and the tooth responded positively to vital testing, because we know that healthy teeth will have a normal response to cold testing and vitality testing, right? So now this was the main part here. my failed pulp cap versus a successful pulp cap. So remember, I did the pulp cap using Dical and an IRM temporary restoration. And the pulp cap failed basically. A root canal was attempted, however, the canals were so, what's the word? Calcified. So the root canal was also unsuccessful, and the treatment ended up being an extraction for this patient. So in the research case, a direct pulp cap was also done. It was on a 47-year-old female with a diagnosis of reversible pulpitis due to a carious lesion located on the occlusal surface of the tooth. So during the excavation of caries, they got a pulp exposure. My patient came in with a pulp exposure. We remember that, right? So it wasn't me that caused it. So I was thinking, maybe that's why it failed, because I don't know when the pulp would have been exposed from before. However, in this research case, the pulp was exposed in a controlled circumstance, right? We agree? So that's one difference. Another difference is that the direct pulp capping was performed using advanced platelet-rich fibrin, whereas my pulp cap was using Dical. And this tooth was actually saved with the platelet-rich fibrin. And next, and this was also done in I think it was a one-step pulp capping. So my patient, she would have taken 3 appointments. Meanwhile, this patient only took 1 appointment, and it was successful. So I just have one last question, which is, can anybody identify what the yellow arrow is trying to indicate after I have said it 10 times? Yes? You could say answer. Try again. Yes. Who said it? McCary? You get a prize. See, incentives, guys, they work. So as you can see here, the tooth has formed the reparative dentin bridge, which is what we wanted. This is not the case. This is not my case. Remember, my case failed. This was the research case. So you can see the dentin bridge there on the radiograph. So in conclusion, I know I was talking long, but today we went through pulp capping, direct and indirect. I hope you guys learned a little something on that. And we also went through pulpitis, reversible and irreversible pulpitis, right? And now that we have went through all the materials as well, I just have one last quiz for you guys, just so I know that this presentation was effective, right? So question 1. Anybody can shout out the answer. So what is the importance of identifying reversible versus irreversible pulpitis in your dental management? Yes. Expound a little. Treatment is important, yes. Yes, what else is important? And it's also important that we stop the progress of the disease, right? All right. So question number 2. So what are the clinical parameters that help you distinguish between direct and indirect pulp capping? Exactly, exposure of the pulp, that is correct. And then the last question is based on the research that I was showing before. So what do you think the best material would have been for the direct pulp cap? Good job. All right, so thank you for listening. I want to give a special thank you to Professor Santosh and Dr. Jones for this opportunity. And I also want to once again thank MSN Laboratories for the opportunity and for sponsoring the event. Thank you.
All right, thank you. I think we can get a louder applause for Miss Brown. A tremendous presentation. I told you, I got a sneak preview and I was impressed, and you did not disappoint. Great job. All right, so we're going to move now to a moderated session of Q&As. So any questions that you all may have based upon the presentation, and questions from our moderator-in-chief, which is our very own UWI graduate from the class of 2018, Dr. Rachel Ann Barras, please.
All right. Thank you, future Dr. Brown. You did so good. I'm so proud of you. All right. So, I want to bring it to you guys. Does anyone have any questions for Ms. Brown? Yeah? Okay, I'm coming to you.
I have a gift for you. I apologize.
Okay. Any other questions? I see a hand going up in the back. Yes? All right, I'm coming. No, don't stay. Okay.
Who has? Okay.
All right.
As long as you can hear.
You can shout out your question.
I wanted to know what is biodentin made out of? What is it? But I finally have an idea what zinc oxide is, right? What is biodentin?
What is? Oh.
Okay, so the audience member wanted to know what is the composition of biodentin?
That's a really good question. I think it's just basically a lab-made form of dentin, if you get what I mean. So it's biodentin. So it's it's made dentin for the tooth, if that helps. Synthetic dentin, that's the correct word. Synthetic dentin. So it's better to pulp cap with that because the body will recognize it more than a foreign material. Right? So biodentin, yeah.
Yeah. Sometimes it's also called bioceramic sealer as well, and it has extended applications in endodontics as well as restorative dentistry. Pardon me? Yeah.
Okay. Oh.
It helps in donating the calcium to the tooth because in the healing process, right, we need the calcium there.
To form the dentin bridge.
And from experience, it's more user-friendly. Traditionally, calcium hydroxide tends to be messy. It's hard to keep in one place, and during the restorative procedure, it's more difficult to control. So with biodentin, it's more easily placed, more user-friendly, and it does its job for a longer time compared to calcium hydroxide that may dispense and not stay in the area desired for enough time for the dental bridge to form.
Oh,
Any other question? Yes? Dean?
In the first case, the patient was 18 or 19, and the
No, 16.
16, yeah.
second case, the patient was
86.
I think that had a factor in the
Yes.
Yeah. So Dane wanted to know if the age difference between the patients in case 1 and case 2 made a difference in the effect of the treatment. So just to recap, the patient in case 1 was 16 and in case 2 they were 86. You have an answer for that?
Yes. So, of course, it made an impact. Of course, we know younger people will heal faster than older people. But because we wanted to do a conservative approach, and as you saw, the patient had lost so many teeth in the arch already, it was the first line treatment to try to save the tooth. So that's why the pulp cap was still attempted, right?
Also, just to add to Dr. Brown's answer, in younger persons, the pulp chamber and pulp canals tend to be wider, whereas in older patients, you have more sclerotic and closed pulpal anatomy. So therefore, it will affect the distribution of the blood vessels in the tooth, and more blood vessels means a higher ability for the tooth to heal, right?
And also, if you can remember, the pulp chambers also were calcified. So given the age, it was kind of a thought that a root canal would have been hard to do anyway. So that's why the pulp cap was the first line of treatment that we used for that patient.
Yeah. Yes?
Do you think the calcification of the pulp had anything to do with maybe the direct orthodontal case, the direct pulp cap not working and not necessarily the material that you used?
I would say no. If anything, I would have hoped that the calcified chambers would have helped the pulp cap. So I would say no. I don't think that would have implemented the success of the pulp cap that was done.
Yeah, I am on the fence with this one a little bit. I mean, who knows? There are a lot of factors that could have contributed, like Ms. Brown said during her presentation. It could have been the exposure of the pinpoint lesion to the oral environment. We know the wide variety of bacteria there that could have affected the health of the pulp, as well as, like we said before, the calcification of the canals, etc.
And also, we didn't know when the pulp exposure happened, because remember, she came in with it exposed already, so that could have also been a factor. And then also she had, what was the word? I think it was a nagging sensation. So it was kind of leading more to irreversible pulpitis than reversible, but as I said, since it was a conservative approach, the first line of treatment was always to try to save the tooth with a pulp cap. And then if anything else, it would just go more invasive, which we did.
Yeah. Any more questions? These are great questions, guys, so keep them coming.
So why would you say like the premature exposure in the in the second case, the premature exposure was a factor? Why would that be the case, that the exposure was a factor instead of it's like when we exposed the pulp in the case that was successful? Why was it? What's the difference?
Okay, so when you expose the pulp, that's a controlled environment. Like at clinic, we are taught to always wear rubber down when we're doing any sort of invasive procedures. Well, in terms of restoration. So the environment would have been more controlled, so you could control the amount of bacteria that was going in there, the saliva, etc. So as opposed to the patient coming in with the exposed pulp, it already exposed everything in the oral cavity, like Dr. Barris was saying. So it was just based on the more controlled environment in the second research case, right?
Yeah, I totally agree with Ms. Brown. In addition, just to give you guys some insights, and for those who may not be well into restorative dentistry yet, when you're excavating decay, cleaning up a dental cavity, we have methods when we get close to the pulp. So in addition to it being controlled, we are very careful in coming close to the pulp. So even though there's an exposure, it's very gentle, right? Compared to, we don't know why there was the exposure, it was fractured, right? So that would be traumatic. And then eating, drinking, she probably had coffee or tea, burning up the pulp, poking at the pulp. It could be pretty traumatic. So that's just to, make the picture a little bit clearer to understand why one would have been, yeah. All right, I saw some hands kind of going up, but they're going back down. Come on, guys, ask the questions. Yes.
Question for the direct pulp trapping. You said that hemostatic treatment is used to control bleeding. How exactly does that work?
So it would so remember I was talking about the cotton pellets. So it would dip the cotton pellet in the hemostatic agent and hold it against the exposure for I think about a couple of minutes, just until the bleeding is stopped. I must apply pressure to, when you got cut, you just hold pressure on it to stop the bleeding. It's the same concept in the tooth.
Yeah, and just to add, like she said, pressure helps to control bleeding. Also, the hemostatic agents that we use contain vasoconstrictors. So they tighten the blood vessels to help further control the bleeding as well.
Any more questions? No? Okay. Thank you again.
All right.
All right, thank you, Dr. Barris and Ms. Brown, and thank you to the audience for those wonderful questions, really great questions. All right, next we are going to hop back over to Dr. Jones, who has a note for us on certification.
Yeah, thanks, Dr. Peart. I will invite Professor Santosh as the chairperson. He's trying not to come on stage, but I found a way to bring him up. Before I start presenting, I throw this out to both dentists here and to the final year students. Is there a difference in the patient's reaction to using limelight versus catalyst and base dicol? No. Go ahead.
So for one, okay. So just for your reference, dicol, well, as Dr. Jones said, is a catalyst and base. Doesn't contain any resin. It's a chemical reaction. Whereas limelight, there is resin added, so it's light cured. So it isn't that, well, the reaction is different. With dicol, I guess the calcium hydroxide is more available. You have better bioavailability. And also, without the resin, it's less irritant to the pulp, right? Because the reason why we don't just etch and bond directly over the pulp is because these solutions could cause damage to the pulp because of their interaction. So I guess the Dical will be safer to use and less irritating.
Concur? Good. Thanks for the concurrence. So our first, as showed on the screen, presentation of certificates for today is to our presenter, Ms. Tiffany Brown. And we'd like to invite MSN to come down, please. And then we want to invite our moderator, Dr. Barras, from the class of 2018. Emphasis on the. And we now invite our esteemed chair, first of many roles that he will be playing. Okay, now we can have Dr. Pitt.
All right. Thanks again, Dr. Jones and Professor Santosh. We're setting up right now for the last presentation this afternoon, which will be from our sponsors, MSN Labs. Last but certainly not least. All right, so Ms. Trishelle Hoorie. Mrs. Hoorie, ready? All right.
Good afternoon, everyone. As Dr. Peart said, I am Trishelle Robinson Hoorie, medical rep at MSN Labs. And before I go into my presentation, I would just like to thank Professor Santosh and Dr. Jones and everyone else for providing MSN with this opportunity to partner with the Dentistry Talks. I really enjoyed the presentation, future Dr. Brown. It was very informative, and thank you again for that. So my presentation today will be very short. I will just be introducing a product that we have in our product basket that we see that fits into the dentist industry. So as you see here, it says MSN, which is the home of novel pain solutions. And then we jump right into what is acute pain. Dr. Brown already told us the answer to this question, so I don't have to go into it much. It just shows you that acute pain is typically self-limited and resolved over days to weeks, but it can persist for 3 months or longer if trauma or acute illness occurs. And we see at the end there where it says pain cannot wait. When a patient enters the clinic or a patient enters your dental offices, they have 3 desires. Their first one is getting rid of the pain, so pain relief. They want you to find the safest alternatives in getting rid of that pain, which leads to limited side effects, right? So a drug that will relieve the pain and is safe for the body, but has less side effects for the patients, right? Managing acute and chronic pain. So when you're managing your pulpitis, am I getting it right? Yes, when you're managing in that case, clinical use of NSAIDs is pretty key, on their ability to reduce, to reduce the synthesis of prostaglandins implicating the pain, fever, and inflammation. However, the most frequent side effects of NSAID is related to the GI toxicity. So most persons are concerned of the GI toxicity of NSAIDs. Right here we have the mechanism of action for our Algic. So our product that we're promoting for your pain and inflammation is Algic, which is aceclofenac, and the plain Algic is aceclofenac 100 milligrams, and we also have Algic P, which is a combination of aceclofenac and paracetamol. So basically here is just showing that Algic blocks the production of the enzyme that is responsible for pain and inflammation, and helps in that process, basically. Right? The solutions. So the solution in managing your acute and chronic pain, your pulpitis, probably after surgery, so post-surgery pain, is our Algic, as I mentioned before, and our Algic P. These both products have been proven to be clinically efficacious. It's a twice daily dosing, and it's more tolerable, so less GI effect on the patients. Right? So that would be one of your safe alternatives with less side effects. And this is just a picture showing a person that is in pain and our solutions that will stop that pain for the patients. So the indications, as I was mentioning before, for Algic and our Algic P, you would have fractures, dislocations, post-operative pain, joint pain, chronic lower back pain, chronic flares in arthritis, body pain with fever and pain associated with tonsillitis, and the others, right? So basically, we're just giving an insight on Algic and Algic P for your patients who are having pain and inflammation. Last slide here shows you a table of drugs. These are NSAIDs on this side here, and it shows the onset of action. Onset of action meaning that this is how long the medication takes to set in to provide the patient with symptomatic relief. As we see at the top here, we have aceclofenac leading that list, which is the key ingredient in our Algic and our Algic P. So if you're looking for a solution for your patients on a fast onset of action, then Algic and Algic P would be the answer to that question. Right, so again, we just want to thank you so much for giving us this opportunity, and I hope that you have a good rest of day. Thank you again.
Thanks, Trishelle. All right, thanks again to Mrs. Trishelle Robinson-Hoorie. All right, before we wrap things up, I'd like to say thank you to all the persons who are present today. For those of you who participated, to Dean Thame, Deputy Dean Crawford Sykes, Dr. Jones, Professor Santosh, just the entire School of Dentistry. We're very proud of this initiative and we hope to keep it going. Now, the Dentistry Talks series of presentations, we hope to have, as Dr. Jones alluded to previously, we hope to have 4 for the year. So this is the first one. You can look forward to 3 more. I know Miss Brown set the bar extremely high, but we're looking forward to what comes in the future. For all those who registered for the presentation today, you will receive a copy of our certificates, so you can look out for that. And I'm happy that all the dental students, I don't know what percentage of the dental students are here, but it seems like a good amount. And so hopefully this experience inspires you to go forward in research, in your clinical aspects, and do the best that you can to finish out school and become the best practitioner as possible. For MSN, looking forward to adding Algic and Algic P to my pain management regimen for my patients. Thank you so much. All right. One quick word from MSN Labs.
So good afternoon, everyone. So I just want to say, future Dr. Brown, on your treatment chart, you'll have to amend it and put a aceclofenac on it.
All right. Well, thank you very much, everyone, and safe travels.